You are now listening to Nailed It, the Orthopedic Surgery Podcast.
Dr. Sears, welcome to the Nailed It Ortho Podcast. Happy to have you on, and welcome to the podcast.
Thanks so much for having me. This is a great media for people interested in orthopedics in the field, and you've done a great job. So I'm really excited to be on. Thank you.
Well, I appreciate it. And today we're going to talk about a more specific topic, but I think a good one nonetheless. We'll talk a little bit about intramedullary fixation and proximal humerus fractures. But before we get to that, we always like to just kind of start off getting to know our guests just a little bit better. And, we know you're a specialist in shoulder and elbow. And I guess there's a question I have for you is, a lot of times we have residents that are listening to this, some medical students as well, and some that are kind of trying to choose between one specialty and the other. So what made you, or what brought you towards, the field of shoulder and elbow?
Yeah, sure. So my journey kind of started as a lot of people, and I went to Colorado State University for college, played rugby, and ended up having a pretty bad shoulder dislocation in college. Had it fixed. Actually underwent thermocapsular shrinkage because I'm
really
back in the late 90s. Didn't get chondrolysis or anything, but that was like right when that was coming around, and ended up having a dislocating my other side and had the same thing, and then came out again. So an open Bankart after that. So I had 3 surgeries. But my surgeon is Dr. Dale Martin in Fort Collins at that time, knew I had an interest in medicine and let me watch a bunch of surgeries with him. And so it kind of started from there. Orthopedics was definitely on the radar through med school, but just shoulder just made sense to me from a kind of a thinking about a perspective after all that. And I just gravitated towards that during residency. And I had a really nice mentor at Loyola Medical Center named Guido Amara, who's at Northwestern now, who was instrumental, kind of guiding me through residency and towards shoulder and elbow, the field of shoulder and elbow.
Yeah, that's awesome. I guess throughout the time I've seen a lot of it has been a little bit of mentors as well as personal experiences, what drives, and there's other things as well, but kind of drives some people to do one specialty versus another. And I think it's cool. Shoulder and elbow is cool. I like shoulder and elbow cases. Hence a reason I'm going into sports. Yeah. Second question I have for you is a question that we've asked sometimes on this podcast that responses are always interesting, and we haven't asked the past couple episodes. So I figured I'd bring it back. Do you have any books that you've gifted to others? This could be a book on orthopedics. It could be a book that has nothing to do with orthopedics, personal development, or whatever it may be. But any book that you have gifted to others, or, have said, hey, you should read this book, for example.
Probably I don't have any great orthopedic books lately off the top of my mind, but I was talking to one of my good friends from med school about one of my favorite books. It's a book by James Clavell. It's called Taipan. Have you ever heard of that book?
No, I haven't heard of that. What's this one about?
It's a little bit of an old school book. I don't know if it's from 70s or 80s, but he wrote a series of books about Asia. And it started out with this book called Shogun about Japan back in the day. And then Taipan is the beginning of Hong Kong in the 1800s. And it's a fictional, but it's very well done. It's about the sea and the ocean and the basically sort of westernization in a way of Hong Kong and that part of Asia. But it has my very favorite ending of any book. The last chapter is just amazing if you can get through the book. That's probably the last book I gifted, but in a way of telling my friend to just buy it.
Yeah, now you have me wondering what the last chapter is. I gotta check it out now. You can build it up
on your free time. It's only like 800 pages or something. So.
No, it might be a good a plane.
Yeah, exactly.
If you have a long flight or something.
Yeah, definitely book on tape for sure.
Oh man, and the last question I have for you, or do you have any interest outside of the field of orthopedics? It can be sports, movies, fishing, whatever it may be, but any interests outside of the field of orthopedics?
Yeah, so I grew up in Colorado and back in Denver. So if you live in Denver, you have to have lots of other outside interests. So I'm an avid skier. I like to exercise on a daily basis, and I have 3 kids and a wife. And my parents live in Denver, and my friends from college live in Denver. So it's mostly outside, getting outside and enjoying all the stuff that the world has to offer from that perspective.
Nice. Yeah, I went skiing for the first time, I think last year. Didn't realize how much of a leg workout it was. I think my quads were sore the next day. But it was a lot of fun.
Yeah, it's just nice being outside, on the mountains. It's a nice sport.
Yeah. And I think with that, we can probably transition to the topic of today. And, we're talking a little bit about proximal humerus fractures and intramedullary fixation. And kind of one thing I like to do is just to create a background, just when we're talking about, these proximal humerus fractures and fixing them. We know there's many different options. You can plate it, you can nail it, you can do a couple of different things. But at the core, what are some of the, this basic principles that you want to avoid, when you're fixing proximal humerus fractures? Like, I guess kind of just the basics of what we need to do, or fracture patterns or characteristics that need, I guess, special attention per se.
Yeah, it's a great question. I mean, these are traditionally very challenging cases. We don't really know who to fix and who not to, on a really global scale. As they're challenging to quantify and to classify, really. I think generally the real displaced fractures that may not heal or heal in a really bad spot to put the bearing surface at risk, you want to be on the lookout for that. And then it seems that, at least in my opinion, the real varus fractures do quite poorly. So where the head's tipped at a less than 110-degree neck shaft angle, those don't do very well by leaving them. However, there are some patients that surprise you, don't want surgery, that do fine with it, even despite a lack of range of motion. So it's a challenging question to answer, but in my opinion, the displaced fractures, the greater tuberosities that are way off, and the grossly varus ones are probably the worst actors.
Okay. And I think that sets a good, precedence, and, we are going to have these fractures, and obviously the talk of the day, or the topic, is going to be intramedullary fixation. So just talking about nails for the humerus, can you kind of just take us through some background of humerus nailing? What are different types of nails, and what are some of the things you should be looking for? For example, I go to these meetings and there'll be vendors and they'll have 8 different nails, and I'm trying to figure out what's what. So can you kind of take us through some of the history of just, intramedullary nail fixation for humerus?
Sure. Is it okay if I kind of scroll through these slides for that?
Yeah. Perfect.
So this is a talk I gave a couple of years ago at one of the alumni meetings, but I kind of went through a lot of the history, of nailing and some of our cases, and I'll just kind of scroll through. So I don't have any disclosures that are relevant to this topic. But I guess, starting out, and I mean, you and I sort of shared the experience that I had of nailing, and my training was what Dick has shows here, 0. Back, before I was out on my own, nailing was basically seen as the work of the devil, and that everyone did poorly, and we were just taught that no one should get a nail outside of those rare pathologic humeral shaft fracture or pending humeral fractures, shaft fractures. But probably the real reason for that, and what my experience has been going through the history and having my own cases, is that these started out with a design and technology that were quite poor, and it kind of just made people think that the whole concept was a failure. So looking through the first generation, which basically means you're just jamming some pins from the down the humeral shaft and hoping that it works. And these are the humerus. There's a lot of rotation and torsional biomechanics to the fracture. And these rush rods or Simon pins, they just didn't have any ability to really control rotation or fracture fragments. And these patients are typically quite osteoporotic or penic, so they're just pulling out, and patients did typically pretty poorly with that. So the second generation at least had some structure to the. It was an actual nail, kind of similar to what you put in the femur. But the worry, at least for these designers, what I think is that they were so worried about violating the humeral head that they thought, okay, let's just put the nail down the lateral aspect of the proximal humerus. And unfortunately, what that did is it just put this right down the middle of the cuff insertion on tuberosity. And so all these patients had pain, shoulder pain that was really cuff based, if anything. This also can go through the fracture segment as well. And so fixing the humerus was hard. If you look at the literature of these, by over 60 or 70% of patients in the literature were having shoulder pain. The other problem with these, and these are some x-rays I've actually gathered from my own clinic of just horrible looking cases.
Oh, these are rough.
They're just bad. Like, where do you put the nail? How deep? The screws are falling out because they can't get fixation in the tuberosity. If you have a series of these and this is all then yeah, it seems like a pretty subpar option for patients. So this is the history until about 10 or 12 years ago, where the third generation nail was designed. And fortunately, the designers of these nails took all that into consideration. So the current nail design, and I'm sorry to put these the product names up there. I don't mean to invoke any industry in this.
No worries.
Okay, good. But now the nails they're designed as being straight nails, so you don't go through the cuff insertion or on the tuberosity. They're smaller, so the footprint in the cartilage is diminished. And I think what's really cool is that there's a poly bushing proximally in these. So when you secure your tuberosity's fixation, it actually screws into the nail, into these poly bushings, and you get fixation through that. So you don't have to rely on the bone.
Okay.
And then some of the newer designs have really nice extramedullary guides. And even one of the company has one that you can even use with long nails. So putting in your distal interlocks or your interfracs are so much easier. So the designs really helped advance the improvement and making this a much more reliable option for patients.
Yeah. So the first generations were more distal rods, and the second are the ones that had a proximal lateral bend. And again, those are kind of inserted right through the cuff. So that was giving people a lot of shoulder pain and dysfunction. And now these nails, again, have a straight nail design and a smaller diameter. And then again, those poly bushings, and that the screw itself screws into the nail. Correct. That's what we're saying.
That's exactly right. Yeah. It's actually gets fixation in the nail, not the bone.
Okay. And so I guess one of the main questions we'll have is, so what is what's the difference between nailing versus plating? Why not plate a lot of these fractures versus nail? What's the difference between these two different types of fixation for these fractures?
Yeah, there's a lot of different concepts between a nail and a plate, and I think that's where some people that are always platers would always plate. Some of the thought is, and I have the slide I think on this in a few.
Yeah, go for it.
Find it. This is just first of all, so yeah, this is just looking at some outcome. It's a little bit of cherry picking. I agree, but just looking at some of the data of plate fixation. Plates are not benign by any stretch. Then some of these plates, in the literature, have complication rates that are high. This 2009 study showed 34% complication rate, which is mostly like intra-articular screw position or reoperation. And then there's a 2017 study that showed that plates had a 45% complication rate from, it's a lot of like penetration of these screws into the articular surface and some AVN as well as some shoulder pain. There's been a bunch of comparison studies between nails and plates. I think what they ultimately showed, this one from 2011 showed that the plate complication rate was much higher, but interestingly enough, there was no difference between the groups in terms of subjective scores at 3 years. But there are two different concepts, and it's kind of a little bit of apples to oranges in terms of like comparing them. In my opinion, some of the advantages and differences of fixing it with a nail versus a plate, really the first one is you just don't have to do as much surgical dissection. So the theory behind that is that you're going to preserve the blood supply to the proximal humerus, both the head, the tuberosities and the surgical neck. And it's because you're putting the nail from the top down, so you're not violating the circumflex vessels around the proximal humerus. So you don't have to open it up. You don't have to do a surgical dissection, and you don't have to put the plate along the lateral aspect of the proximal humerus, which is where some of the important blood supply lies.
Okay. That makes sense. And one of the things that I guess they teach a lot or we hear a lot, I know the thought process is before we used to think that most of the blood supply comes from the anterior circumflex arteries. And now some are saying that it's coming from the posterior circumflex arteries. And I guess, I don't know if it's just a question, is like theoretically, if you're doing a delta pec approach, you may go through some of the anterior blood supply, but do you also get some of the posterior supply if you're plating just laterally, like with a deltoid split? Are you worried about getting any of that supply?
Yeah, I think so, because there's a fair amount of anastomosis. I mean, it's there's collateral circulation, and Gerber described this one important vessel. I think this was like 2007 or 11 or so, but there's an anastomosis between the deltoid thoracic acromial artery to the anterolateral anterior circumflex artery. And you'll see that if you're doing a total shoulder, next time you do one, you do the delta pectoral approach at the anterior aspect of the deltoid insertion, just lateral to the pec major. There's this artery there, and if you don't electrocauterize it during those surgeries, it bleeds like stink. And that artery we think is pretty important for the proximal humerus. Well, when you do a plate, that plate goes basically right down where that artery is, and you have to, violate that particular blood supply. So does that contribute, to diminishing the blood supply of the proximal humerus with plating? I mean, it probably does to a degree, but it's never been quantified.
Okay, yeah, that makes sense, and I'm gonna look for that artery next time I go. Next time I'm doing a total shoulder, and so is there any difference, I guess, biomechanic wise, when you're looking at nails and plates? But I guess we're more focusing on nails. So when you're looking at nails, anything biomechanically that's important to understand, I guess, conceptualize when we're thinking of how we're treating these with nails?
So the literature is all over the place on this. There are some that say nails are better or plates are better. It's all kind of based, I think, the methodology. I think the one real advantage of the nail is that, well, there's two. I guess it's medialized, so you're closer to the calcar, and then you also gain a point of fixation at the very top of the nail. If you don't insert it too deep, that top of the nail helps prevent the humeral head from tipping into varus, and it's called a fifth point of fixation. There was an interesting meta-analysis done JOT by Young in 2015. They looked at 250 patients, about that many, just looking into loss. What's the biggest risk of loss of postoperative reduction? And they found 4 variables that matter: osteoporosis, varus displacement when of the fracture under 110 degrees, medial comminution, and then insufficient medial calcar fixation. And to me, the nail does a better job of addressing those types of issues than a laterally based plate, and primarily because you're medializing it, and you have this 5th point of fixation to help with the calcar.
Yeah, and I guess one question that I have conceptual wise is, in my head, like when you think about if you're plating, you think about screw cutout or penetrance, or you think like you have, I guess, intra-op, you think you have your screw lengths are great, you check your fluoro, and then some months later the head collapses and screws penetrate from there. That, in your experience, do you see anything similar like that with the nails? Like you have a good, you've put your nail in and you have a good point. It's not necessarily too proud, but then you may get some collapse and the nail becomes proud. Is that something that you ever see?
Yeah, that can certainly happen, without question. I think the advantage, at least of one of the companies, not all the companies that have the nail, the 3rd generation, but one of the companies has the tuberosity screw fixation that's not pointed towards the head. So it's pointed basically from anterior to lateral, anterior to posterior, or really posterior to anterior. So if there is collapse, you really don't see that head, like intra-articular head penetration of the screw.
Right.
So that's helpful. And then what I've done, because that's certainly a concern, is there is a calcar screw that is similar to the plate. So you can put that in as a kickstand, but you can do this with a plate, but you can inject some of these newer bone grafts that are basically calcium phosphate that will you can put it right in the metastasis, right where the comminution is, that will hardens in 20 minutes to 1 day to the strength of a cortical bone, and that acts as a nice like a nice almost new screw or fixate, or almost cement fixation in the metastasis that then becomes bone over time.
Is that like some of the stuff I'm like montage, or not no names, I'm not getting paid by anybody to say this, but is that like some of that type of material?
Yeah, it's a little bit. I mean, I'm not getting paid. I'll just say names because it makes it easier for everyone. But
yeah,
Norion is the Synthes one, and Prodence is the Wright Medical one. But
okay,
you basically inject it as it's like runny liquid, and then it just hardens wherever you want. So you can do it even percutaneously. And you can just put it right into that area that the patient needs.
Oh, okay, cool. And another question I have is, so what patients, I guess, in your practice are indicated for intramedullary nail fixation? This patient comes in and you say, okay, that's the one that we should nail, versus maybe that we should probably do something else with this patient. I guess your kind of indications.
Yeah, we still are treating most patients non-operatively, of course. However, I feel like my indications for nailing have widened a little bit, because I feel like I've had success, and I can give patients a good result with it. So I don't like the patients that have tipped into varus quite a bit. Certainly don't like if there's a wide displacement of either the greater tuberosity or the neck shaft, if it's a 2-part. So I say this is rough, but probably a varus displacement, certainly under 110, but maybe 120, you consider it. You certainly take into individual patients, who's playing tennis, who's in a wheelchair, all that matters.
Right.
Myself, my partner we do very few reverse for fracture. Although there's, if it's really smashed, head split, tuberosities in 1 million pieces, and they're low demand, that'd probably be a reverse for fracture. But my go-to is probably the nail over some of the other surgical options.
Okay. And can you, so we had this patient, we see them, they have a proximal humerus fracture, and we've decided to go ahead, and proceed with intramedullary nailing. Can you kind of take us through, your setup, how you get your imaging? And for those that are listening on the audio podcast, we also have a video on YouTube if you'd like to check it out and see some of the things that we're talking about. We will try to describe everything as best as we can for audio, but can you kind of take us through some of kind of how you set these patients up, how you get your imaging, and what's important to be able to interpret the imaging?
Yeah, absolutely. I feel like my own kind of evolution of doing nail, I never did it as a resident or fellow, and then when came to Denver, it's not my current partner now, but my partner back then, Armand Hatzidakis, who helped develop the nail, told me about it, and I was skeptical. But then I did a couple cases early on where it was a displaced two-part fracture, and I plated them. I did a deltoid pec approach. I wasn't great at getting imaging, and I put the plate on. I felt like I got it fixed properly, but then in post-op x-rays, it was still, the head was displaced from the shaft by 50-60%. It was humbling, and so I kind of developed a way of taking images that helped. And then I thought, the nail, if you put it in right, it's going to shish kebab those fragments, and it's going to, you have to basically put it in right, or you have to get those pieces reduced to put it in right. So that was kind of my evolution and how I kind of developed, and how the technique has developed for myself. My indications, ideal indications are a displaced two-part fracture is the best place for the nail. It works great for those. You can typically put in percutaneously, so that's why I put a younger patient who tip off. Almost all of those that need surgery are displaced two parts. So you can put through like tiny little portals, just like a scope. And it also works great for patients with poor bone quality. But I have this is my setup here. So this is a case we did a couple of years ago. And I like to put the patient in a beach chair position with about 30 to 40 degrees of inclination. That helps with imaging. And I always have the C-arm come in from the contralateral side. With a plate, when you're manipulating it, you're moving the arm all around to get the plate in the right spot or to deal with deltoid tensioning, et cetera. But this one with the nail, you just put the arm in an arm holder and you put it in the gunslinger or neutral position, and it stays in there the whole case. And if you do that, you can really get reproducible images of the head segment that you can interpret, because they look just like the ones you get in the office. So just talking about this, guys, I feel like it's so important. This was really a key of my own learning experience. So these are the images that I want to get in the operating room. You want to get a Gracie view and a lateral view. And you want to get reproduced images that you see all the time in the clinic that your brain can just interpret. Yes, it's in the right spot, or no, it's not in the right spot. So these are two images from my office that I get all the time. But the proximal humerus just internally rotated, and it's a lateral view on the bottom, and then a Gracie view on the top. This is my son, William. And
Love it.
This is a bone that I basically probably got off the dark web. I got it from India. It was sent to me. It's a real human humerus.
Nice. I like it.
It's probably totally sketchy. It's like a great. But I wanted to, so I got this little wire and I wrapped it around the key landmarks and I taped it. It looks kind of interesting there. But I went to the fluoro suite and took a bunch of x-rays with that wire around the key anatomic parts of the proximal humerus, and then took some x-rays. So these are the two x-rays I want to reproduce in the operating room. So the Gracie view with 30 degrees of external rotation, and then a lateral view, which we've termed as the precipice view, because it's kind of like the side of a mountain.
Okay.
You can see the bicipital groove, the greater tuberosity is outlined with the wire. And then, and this was 40 degrees of internal rotation and 50 degrees of inferior tilt. But also you see the infraspinatus tubercle and the teres minor tubercle. It's where those tendons insert. That bone is some of the best bone of the proximal humerus. So if you can find that and you can isolate it, you can fix the tuberosity in those spots, and it usually will be helpful for fixation.
Okay.
So, so basically that's the imaging part that I like. And there's some examples, case examples using this, but every case I just get these two views. So the C-arm comes in from the contralateral side, you get a Gracie view, and you figure it out before the case starts, and you get a lateral view, and you're just basically going back and forth between those views with the arm just staying in the gunslinger position.
Yeah. So with the Gracie, I mean, so you just kind of, in order to get a lateral, you just have the C-arm just see over a little bit, and it's not necessarily, oh yeah, you just have them kind of just see over, as in see towards you, and that's how you're getting the lateral view. And then your Gracie, it's kind of like AP, but not really. But they're kind of, they just come straight in from the other side with a little bit of tilt. Is that right?
That's right. You kind of so they come from the other side, and the C-arm tilt is matching the tilt of the bed, and then you just basically have them, orbit towards them for the Gracie view, about 30 degrees roughly, and then over the top of the patient for the lateral view, which is about roughly 40 degrees, 30 to 40 degrees.
Okay. And so we know with these, imaging, very important, once you have, the patient positioned, prepped and ready, and, we've gotten the appropriate imaging. Can you take us through the ideal starting point? We know that's, super important when we're nailing things, especially when we're nailing hips or femurs. And I assume the same thing when we're nailing humeruses. So can you take us through what the ideal starting point is and what we should be looking for on x-rays?
Yeah, so I think this is probably one of the hardest parts of getting started with nailing is, where do you start? I mean, there's not much data on that and how to do it. So we did a study on this, and it's published in JSCS International, but we wanted to determine what would be the ideal starting point. So, I thought this study was interesting. It kind of answers that to a degree. I'll just go through it real quick, just to highlight it. So we thought that a more medial starting point, so starting in the articular cartilage rather than in the cuff insertion, would be safer. So we got 10 cadavers, and we basically grouped them into two groups. We placed the nail in all those cadavers. I mean, there's no fracture. There's just like sawbones, basically. And so the first group, we placed the guide pin either medial or through the CA ligament, so where that inserts on the shoulder, or it was lateral to the CA ligament. So CA ligament was kind of our key of medial versus lateral. And then we just did a big anatomic analysis and radiographic analysis. So this is a picture of that study. The guide pin is going through the CA ligament as it comes off the acromion. And you can kind of see, well, this is what the deltoid released.
Right, what it looks like.
This is one of Dr. Garagos and my co-fellows from back in the day, Peter Johnson, who's in Maryland, who did all the imaging. But this is the C-arm, so we imaged the hand or the arm. And what we found is if your starting point in terms of where the guide pin goes in is medial to the CA ligament or through the CA ligament, you have a safer distance from the axillary nerve with your screw fixation proximally. You have tuberosity screw fixation that's closer to those tubercles that are so important, and you have a wider spread of these interlocked screws proximally. So you get better bone coverage by placing the nail medial or through the CA ligament. In terms of the rotator cuff, that's the big problem with the bent nails is it violates the cuff. So with the medial specimens, all of them went through muscle, and that's not a problem. Even a nail that's 10 millimeters. I mean, we put an 8 millimeter cannula through the infraspinatus every shoulder scope we do, basically. So as long as it goes through the muscle, it's not a problem. Lateral to the CA ligament, we actually had two of these specimens that had a full cuff tendon disruption, which was a problem. And then we try to correlate this to like a starting point from a radiographic perspective. And what we found, the group with the medial starting point, if you look at the width of the greater tuberosity, and then you take that exact width and go medial to the lateral margin of the articular side of the surface of the humeral head, and you start there, that is ideal starting point on the Gracie do. And then you want to be right in the middle on the precipice or lateral view.
Now, a question I had, because Senning and I were doing this a little while back, and we were getting somewhat frustrated trying to get a starting point because the acromion, I guess, was kind of stopping us or blocking our way. So we had to try to maneuver the arm or adduct the proximal segment to get a good starting point. Do you ever run into that problem? Or if you do you have any tips or tricks to not run into that problem?
No, I'm glad you brought that up because this is 10 specimens. It's not like the real world, of course. So when that happens, and it's certainly not unheard of for sure, I'll see if I can extend the arm a little bit further without disrupting the reduction. That's most ideal, and that works most of the time. The other two options you have are to either push the posterior humerus forward, so just manually push it forward so you can clear the acromion. And there are some patients you just have to go through Nervisor's portal, which is which is medial to the acromion, basically. And that works. That works as well too. That puts the starting point pretty far medial, but it's a good bailout if you need to.
I want to give myself a little pat on the back because that was one of my suggestions.
There you go.
And our attending was like, all right, we're getting a little sportsy here. I was like, hey, is this a thought? Trauma guys,
Yeah, totally.
Oh, man. So that, starting point makes sense. Now, what about some of our proximal interlocking screws? Is there an ideal placement for those? You talked a little bit earlier about, getting screw fixation into the, tuberosities and, what any tips or tricks for that, or where should they end up at?
Yeah. So, I think this is your ideal position of the nail. So I always try and get this particular nail design, which was also part of the study that we did. It has two screws that can go in the tuberosity, one in the lesser and one in the calcar. So if you can if you can get what's called the greater tuberosity high screw at the level of the infraspinatus tubercle, that's ideal. And then the greater low should be at the level of the teres tubercle. And that usually positions your nail depth at an appropriate depth as well.
Oh, okay. And one other question: short nail versus long nail. Do you always go short nail, or do you ever have an indication for a long nail? If there's just a spiral that goes a little distal, or what are you doing, a short nail versus a long nail? Short nail for the most part works for almost all these proximal humerus fractures. This nail, I think, is 130 millimeters in length. So if it kind of extends into the proximal diaphysis and you're worried at all, I would just go to a longer nail. Okay.
Yeah.
All right, that makes sense. And so, if you want to kind of walk us through some. I know we have some slides with some cases here. You want to just walk us through some of these cases, and I guess kind of high important parts, of fixing these, or things that we need to know. And one more thing: do most of these nails have a design where you can put a calcar screw in? Do you put that in almost every time, or just sometimes?
Yeah, I think that's I don't know if it's controversial, but people don't really, I always put it in. I just feel
Okay.
like the varus collapse is such a problem. Even for younger people with good bone, it's easy to put it in. That screw, interestingly enough, is the closest screw to the axillary nerve. So one of the critiques might be, well, are you violating the axillary nerve with that screw, or are you risking it? I personally have not ever seen an axillary nerve documented injury from that screw. And you put it in, you spread, and you get it down. But I always put the screw in.
Oh, okay. Okay. All right, cool. Yeah, but yeah, if you are would like to walk us through some of these cases, we can go through a couple of them and talk about the high points of what was important and what we got.
Sure. So this is a 22-year-old female, great bone, but here in Colorado, this is the most 22-year-olds who have a proximal humerus fracture. We're doing this. She was snowboarding. It's she's quite a bit of varus. It's a little bit distal to the neck, but you just young active people. I tend to have a lower threshold for doing stuff for somebody like this. So she elected to have surgery. For her, you could basically just pull traction on the arm and it reduced it.
Okay.
So you just pull a little bit of gentle traction. You don't even have to get it in the right spot. Unfortunately, this is a different, where the images is a little bit different case where I'm actually reducing with the cob, but it's showing, this is the Gracie view. This is the position of the C-arm. And this is what you want your brain to think about when you're seeing this, with the Gracie view on the bottom right, where you have, you see the tuberosity. It's where you see it, you're seeing it all the time. So you're not getting fooled. So this is the starting point for her. It's right through the humeral head. It's about greater tuberosities width medial to the lateral margin of the articular cartilage. This is the Y lateral, the precipice view. So it's coming over the top about 40 degrees. And that's the starting point from over the top. And again, trying to recreate that X-ray on the bottom. So at 5 weeks, these show tremendous healing early on, which was one of the other things or reasons why I liked it so much. I mean, at 5 weeks, you're already seeing a fair amount of callus around the fracture. That's the depth. She's moving it at 5 weeks. Can't even see the incisions. And then, at 6 months, it's already remodeled.
Yeah, that looks good.
And that's her at 6 months. And again, no incisions. So that for a young person with a two-part, it's a home run. It's a slam dunk. You're high-fiving the patient in 3 weeks. It's awesome. This is probably the more common, this 58-year-old, she's active, but not like that. And, she's tipped into varus. It's another two-part. There's probably some extension in the tuberosity, but for the most part, a two-part. And this is for her. This is how we did it. C-arms coming from our side, and you can make a little stab incision laterally, and it's a little bit lateral anterior, and you can put a cob or a joker or any instrument through the fracture into the head and really manipulate the head out of varus or out of retroversion. And so that's how we were able to reduce her just percutaneously. And a lot of times it just comes right over. I would say if it's an osteoporotic older patient, you got to be careful just jamming into the head and pulling it back. You almost want to put a cob or something across to the medial fracture and lift the head out instead of jamming it in there, because you can sometimes penetrate the head. But for her, it was easy to just manipulate it on both the Gracie and the lateral.
Okay.
And then, there's our ideal starting point again on AP and lateral, and then holding the reduction. And then here's our nail after we put it in. This particular nail design, that you can tell the depth because it's the bottom part of the indention proximally. And usually you want to get it, you don't want it crowded, of course, but you don't want it too deep either. And for her, if you look at the Calcar screw, that's exactly where you want it. That thing is a complete kickstand for her.
Right. And just to reiterate on our interlocks, again, ideally we wanted one of our screws to be kind of at the level of the greater tuberosity, at the level of the infraspinatus tubercle, and then another one at the level of the teres tubercle, and then just, lesser tuberosity screw, which it looks like you have, right here on this image. And distally, these are just, just some interlocking. Is it one or two distally? Or does it, if it's just more unstable, you just go with two?
Yeah, it's a good question. This nail is designed at the distal screw is a more proximal one. If you just put that in, it can collapse or settle. And I don't know if that matters as much in the proximal humerus as it certainly matters with subtrochanteric or intertrochanteric, where it settles. For the most part, I've just been putting in two to help with rotation, because look at how wide the canal is compared to the nail, and there's some rotational maybe issues. But in theory, if you could let it settle, but I just try and get it anatomic and fix it that way.
Okay. All right. Sounds good. Good case.
And then this was her, 12 weeks out, and she's got some motion. We did this all percutaneously as well. So this is, I put 4-part, it's not a real 4-part where the pieces are all over the place, but it's, it involves the head falling into varus. This is a labor. The greater's involved, the lesser's involved on the CT, which I didn't show, but this is how you kind of do these. You can do this all percutaneously as well. And this is pulling the head out of varus, kind of over reducing the head this is a joker. And then we use a ball spike pusher to kind of manipulate the greater tuberosity a little bit in better position. And then you kind of like push it under the head, but you can do this all percutaneously without violating the blood supply as well.
Okay. So with that one, you just had a small incision laterally, and then obviously superiorly, that's where you're going through with the not joker, ball spike pusher, and then you're holding those in place while you're getting your starting point as well. Is that right?
That's right. So we pin
it. Yeah.
We pin those. I would say I think this one we did fine with a perk approach, but over the last couple of years, I've kind of have been less hesitant to open up for the greater tuberosity. And to do that, you do an anterior or a lateral acromial incision or approach, kind of like an open rotator cuff. So you're not doing a deltoid pec or violating the blood supply, but you can split the deltoid, get the tuberosity into a really nice spot and pin it, and not violate the blood supply at all. It is hard to interpret where the greater tuberosity is at times when you do it percutaneously and get in the right spot. But this one, then we were able to pin it, and those are we use I usually use 2 drill bits to hold it. That's at the teres tubercle and the infratubercle, and then this is with the nail in, and then we grafted him. I think, let's see here. Yeah, you can kind of see on the top view, there's a little density in the
I see.
Yeah. And that's that bone graft.
So, I think what are the, there are a lot of different techniques, different procedures to fix many things, but what are some of the, I guess you could say, the downfalls or the things that you should worry about when you're nailing, when you're nailing these proximal humerus fractures?
I think you got to really get the nail height right. If it's too deep, you'll lose fixation. You'll lose that 5th point, but you also lose some of the fixation of the calcar screw and the tuberosity screws. So that's definitely a pitfall. Some people will try and do this through a deltoid pectoral approach because that's just what we're used to, but it's really hard to get the starting point posterior enough when you do that. So all these starting points, even if you open it, are done through a little poke hole where you want it just basically put the guide pin in percutaneously to the right spot and make maybe a 1 centimeter incision and put the nail in percutaneously, even if you're doing any other open approach to it. And then, I guess sacrificing tuberosity reduction for, because of what you're dealing with the nail. So, I mean, if there's a lesser tuberosity that's off, you can do a small deltopectoral approach and put that in the right spot. And then also do a posterior approach to a greater that's way off. And you're not obligated to go all through one approach of the deltopectoral.
Okay. No, I don't think I've seen the posterior approach to the tuberosity, but I've seen what you're talking about with, delta split and obviously the deltopec approach. And I know you had a couple more cases here we could go through. I know you had some more complex.
There's some more kind of interesting cases. This is a young guy. It's not too displaced. He wanted to ski on the lateral view. It's not a great x-ray, but he's kind of tilted posteriorly. So he ended up having just a percutaneously placed nail, and he was snowboarding in 6 weeks. Just a couple other quick younger people cases. I feel like they're interesting. A comminution proximally. This is the shortest lawn nail this company has. It's about 210 centimeters or so. So for somebody like that, this type of a fracture pattern, I would do a short lawn nail.
Right.
And then that was her cosmesis.
Looks good.
So, here's, an older patient. She's got medical issues, prednisone, osteoporosis. She's on COPD, but she's way embarrassed. She's got calcar comminution and disruption. So this is the bad actor. I feel like with a plate, it's hard to like hold her in that position. That was my experience from training. This is 2 years out. So that white, she got injected with some real calcium phosphate that takes a long time to go away. The newer stuff does not, but she healed great. And that was all done percutaneously as well. Here's another one, 61-year-old female. So she's a bone marrow transplant, prednisone, osteoporosis, way embarrassed. These can be challenging, and she had it placed percutaneously with grafting as well in the canal or in the metastasis. So I really feel like that helps prevent the varus collapse. 6 weeks.
Is the graft stuff, is that expensive? Just I guess just personal, just a quick just for my own knowledge. is that expensive? Or
I've been told it's not very expensive. But I couldn't quote a price or anything, but it's not, it's not like some of these, spine things or
right. Yeah. Those cost some money. And so for a lot of these that you're showing, it looks like, you can kind of use a jake and try to percutaneously lift the head back on top of the segment. And then for your more comminuted ones, you're using a different combination of using a joker or a ball spike pusher or a little mini open approach and using wires to hold it in place and then nail. Any other techniques or tips or tricks that you may have for when we're nailing these proximal humerus fractures? I'm hoping people listen to this and they're like, oh, okay, maybe that may be something we can try, or go to a course or try it out in a lab somewhere first, and then try it out on a patient.
Yeah, I think Below had a nice study a year or two ago talking about how to reduce it with the nail and where to put the nail if it's embarrassed or valgus. The nail can be helpful. The more medial you put the starting point will help kind of tip it posteriorly or in the varus. But my personal opinion is I've had it. That's too nuanced. Like I like to just get it in the right spot and then put the nail on around it. And as long as you are pinning it using Steinman pins as joysticks, using traction on the arm through the arm holder, and then getting in the right spot on both AP and lateral imaging with the joker and holding it there while you put the implant in has been helpful. The starting hole for this, you can use an awl where you kind of core it out, or a reamer. I always put the reamer on drill, so you're just drilling through it. You're not pushing down on the head. That's been helpful too.
Okay. Okay, cool. Yeah. And I guess long-term follow-up or the patients that you've had follow-up, again, obviously this one 18 months. For the most part, these patients are doing well. Any complications or anything that you should note for in the long term? Have you had reoperate on any of these patients or anything?
Oh, yeah, absolutely. So we collect our data on this. We have about 110 people or so with 1 year follow-up, and a number with 2 year and 5 year, and a couple 7 year. The reoperation rate, at least in our office, for those 110 or so patients at a year out, is about, I'm quite off the top of my head, but about 13 to 15%. So most of the complications are stiffness. We're in terms of like reoperation rate, where you got to go in and do an arthroscopic or capsule release or remove a prominent screw. We've had our AVN rates about 3 to 4% that required, conversion to a reverse. And there are some patients, maybe two, that had arthritis that needed conversion to an arthroplasty. So it's certainly not perfect, but I think it gives patients a good option.
Right. Okay, perfect. Yeah, Dr. Sears, I think this has been great talk, and learn a lot about nailing proximal humerus fractures. I know we have a video of kind of going through some of the floor shots I could play really quick if we want to talk about that and before we wrap up here.
Yeah, that'd be great.
All right, great. So let's we can touch base and we can go through some of these fluoro shots, and this is kind of almost telling the story of the case and how you did it. So let's go play here.
Yeah, so this is a case. These are all consecutive floor shots of a case where I just had our C-arm tech just save all these, and this is just kind of almost like a black and white movie of it, I guess. Like I just was scrolling through these sequential images, and this kind of, I guess, tells us the story of the nail. This is a patient with the humeral shaft fracture.
Okay.
So she's got some underlying arthritis of the head, which is I guess a concern. She had no history of shoulder pain per patient, but she definitely has arthritis. You couldn't really do an arthroplasty, at least in my opinion, because it's too distal. So we wanted to fix it with a nail and get that fixed so she could use it. She tried bracing for about 2 weeks and just failed miserably. Her skin was just sloughing. It was not working. So these are a little bit more nuanced, where it's a humeral shaft fracture. We want the perfect starting point proximally, and then we got to get it into the distal portion or piece. It's really hard to get it without just opening up a little tiny bit. It's not like I feel like it's harder than the femoral fractures. Yeah.
Right.
This is that finger device. You'd probably use that for the femurs, and
yeah.
It's helpful to get it in. And I think I got it in, but the fracture was just so displaced, we ended up putting open and put a little clamp on it. So then we're like struggling here with getting the images distally with the C-arm, but so we got the fracture spanned at this point. And then trying to keep it close reduced to get the nail in, but it just looks like it was too displaced. So ended up opening up and basically made like a 2 centimeter incision, and then put a little clamp on it. Yeah.
Right there. Right.
Yes.
And you started off again, you used a one of the sharp reamers on drill. So you reamed, you opened the canal proximally, then you put your guide wire down. You use the finger. I forgot the name of the tool. What was it called one more time?
I call it finger. I don't know if it's.
I've heard that term before. I've used it one time on a difficult, I think a subchoke we used it for. And use that to help get the guide wire down, and now you made your incision and are clamping this fracture, getting imaging.
Yeah, imaging was a little bit of a struggle there, but this you ream, but you can use either a 7 or 8 millimeter diameter nail for this, and so we reamed to For her, up to an 8.5 reamer, and then
Okay.
this is an 8 millimeter diameter nail. So we're just putting our fixing it proximally here, and I just use I think two screws on most of these. And then distally is a little bit of a challenge. I mean, historically, you'd have to do perfect circles, and then you're going right where the radial nerve is and the median nerve, and it's a problem, and you're still there. But this particular implant has this guide. You can't really see its carbon, but it's really helpful. So fix it distally, and then that's me injecting some graft into the fracture site percutaneously.
For our distal, is the guy that goes straight down to, does it work with some blunt dissection and it goes down the bone to avoid hitting any nerves or anything?
That's exactly. There's a little cannula, a metal cannula that goes through those little slots. And so I just make like a small portal incision and then really bluntly dissect down to bone, and then make sure the cannula is all the way down on bone. Because that is a little bit of tiger country there.
Right. Well, Dr. Sears, this has been, I learned a lot for sure, definitely on nailing proximal humerus fracture. I think it's been a great talk. Really appreciate you coming on the podcast and taking the time out of your day to come on and go through your cases and talk about different techniques and different, approaches and how you set everything up and the imaging. And we talked about biomechanics. We talked about some anatomy as well as just some operative pearls. So really appreciate that. And we always, at the end of our talks, we always give away for our guests to have listeners follow you. If you have any social media that you want them to follow you on, go for it. If you have a site you want people to check you out on, or anything that you want to share, you can totally go for it.
Well, thanks. First of all, thanks for having me. It's a little bit of an obscure topic, but but this has been a real light bulb moment, part of my post-training career, where this has really changed my practice. The nail has. So I really appreciate having me on to talk about it, and what a great forum you have. I do have a website. It's denvershoulderandelbow.com. But if anyone would like this talk or want to talk about any cases or anything, my email is bwsers, so bwsears@gmail. Please email me for any reason. It's just happy to be here. So thanks for spending the time with me. It's been fun.
Oh, it's been great. And for those that are listening, please go and leave us a review. Let us know how much you enjoyed this episode talking about proximal humerus or humeral nailing. And go ahead and hit the subscribe button. We will see you all next week for the next episode.